some statistics says basically 60-65% of male smokers, male population smoke, and up to 4 to 5 or maybe more of female smoke, back to male and child. So that is one of the major issue. We basically focus on Chinese and COPD. But despite of all this issue, we don't have in BC, we have not seen any basically culturally and linguistically relevant educational material or information. That doesn't mean we don't have anything translated to Mandarin or Cantonese or simplified and traditional, but it's not basically by the involvement of people, it's not the community based, not involvement of the key informants and the physicians. So what we basically wanted to do to come up with the base, to assess the baseline information about the beliefs and also the perception and the practice related to COPD and health literacy. Again, we want to basically, from today's and yesterday definition, we try to look at the access issue and understanding and also to try to evaluation part. And again, that would be very hard to come up with all aspects of health literacy in one study. So the major basically objective was to come up with some baseline information. And the goal was to develop educational materials which was basically community-based, relevant culturally, linguistically. And we tried to come up to find, to understand the link between language and health needs, and basically the cultural language and health needs, and link it to health outcome. And basically challenges faced by people from different cultures, specifically in terms of accessing to right information and timely information, and also to health services. And to find a practical communication, how we can basically, the best way to communicate with them. So from the initial focus groups, back to 2004, 2005, and 2007 I did with Mark, we came up with the idea that people say, oh, we love to basically to see the video format. Even Marina and I and the other people, we did a study on diabetic back to 2006 or 2007, also in Latin American. We find exactly the same issue. So the issue is not just for COPD, for people who have the chronic, they would like to see in the format they understand, because it seems the written format of the information is very hard for people to follow. And they would like to see more visual and, again, relevant to the basically language. So the study was basically a combination of the both qualitative and quantitative. We did some focus group and with the people, patients, family members, and also with key informants of people, basically well-known in the community, champions, and we will talk a little bit about that. Also, we basically, from the information from the focus group and interview, we came up with the idea to develop educational intervention framework, which actually came up with the material also, and tried to come up with a very basic preliminary validation. In the pilot study, is not going to be real validation, because in the RCT, big RCT, we need a huge number. So we had a few just number I'm going to share with you very soon. So the qualitative study, the focus group and interview help us to come up to basically what does the patient need, actually what they need, what information they like. Because again, if you go to the most of the educational information about COPD, that is a huge number of the pages you can see, lots of information, but it is actually relevant to people. This is exactly what they need to know. And basically, that is what we wanted to know, what exactly they need. Because some of you guys this morning said, or maybe Marina said, we need to go to focus on exactly what they need, how we are going to improve. I learned yesterday and today from Scott that maybe numeracy of people from different cultures is high, but when coming to document literacy, so if we need to come up with real need before we come up with the intervention to improve it. To identify the key informant and champions, who are the key informant? I can say, okay, the key informant is the highly educated, but maybe not. The key informant might be an elderly in the community who everybody trusted. So we asked the person to come to the study. That is very important. The people seeing the people from the very important and well-known person from their own community. And then that's a very crucial part of a study. We try to involve patients, family members, and community members in our educational study, from the beginning to the end to dissemination. So that means we involve not the physicians, which most likely the case of many of the educational intervention and educational materials. We also try to involve patients and the family members. You know, I was talking with Sandra Smith over the lunch. I said one of the problem in health, basically health system in Canada is actually I learned it from Marina back to many years. She exactly said the health system in Canada is just have two chairs for physician and for patient. I never forget that we said many years ago to me. That is exactly true because we don't see any room for the patient family members. We have something we call immediate caregiver at home. That could be nephew, niece, granddaughter, daughter-in-law. In some, for example, Punjabi community, I don't know if you know, but in Punjabi community, that's a very basically cultural issue that the daughter-in-law is a part of her duty to take care of mother-in-law if she has any problem. So she has to cover everything. She has to go to doctor. So if our healthcare system is preventing the involvement of people, family members, so we are going to just go one way to educate patient is not basically work. So we tried to come up with some involvement of people. So we came up with the videos role played by patient. That's very hard. 87, 86 years old patient, how role play? That is basically, we did it. We involved them in the workshop. We taught them how to role play, and actually the patient and the family members role played on the videos. Also, we developed the other video. We called them knowledge video. That was the patient role played or community video. We also developed knowledge video. Knowledge video, again, not the person who speaks English, the person who speaks the same culture, but not only speak, also understand the cultural barriers, cultural issue, cultural beliefs. So we try to come up with both combination of community-based and knowledge-based video, again, based on the needs which we already collected in our study. And we try to come up with the community event to outreach people. So what we learned from the very basic qualitative study, of course, in many studies you can see the language issue, lack of adequate access to useful and relevant information. That is very crucial because it's going back later to communication with the physician. Most of the basic patients we interview, they said, my best source of information is my physician. And again, I was talking with Sandra, and I said, most patients not giving enough information to the patient, just because they said, okay, if we give the information, they are going to ask more questions. If we give more information, they are going to ask more. So that means the communication, not only the language issue, but also an issue of the practical part of the healthcare system, because they are not practically communicate with the patient related to disease. And also the cultural belief and practice, of course, we heard many times they said, oh, I don't need medication because whenever I have a pain, a problem, I'm going to see my doctor. Or basically, the medication is not helpful or not useful because why I take the medication. So the control medication, specifically very true and very important in asthma and COPD, is not useful for many of those people. Knowledge about the smoking. Many of people say, oh, smoking? My doctor tell me, you want to quit? Forget about that. You cannot quit. If you smoke for 25 years, continue. That is many times repeated by patients. And the patient say, my body needs nicotine. My doctor also tell me, don't quit. So they don't know the relationship between smoking and many lung problems. So that is one of the major issues. And they are basically ashamed to use the medication because they say people think I have a TB or other problems, so they don't use medication when they go for social party or when to getting together. So that is major issue we find from the qualitative. Then we came to the more RCT. We tried to come up with basically a larger number. That is very hard to find. 80, 60 plus age old people. We have 134 Mandarin and Cantonese speaking patients with physician diagnosed COPD. 90 of them participated in basic RCT. We randomly assigned them to 4 groups. 27 participated in the focus groups to come up with initial idea, and 16 of those patients participated in video development stage. But then again, we have the 4 groups. We have 2 videos, community videos and the knowledge video. So we have one group just watch community video, the other group watch knowledge video, the other third group watch both videos. But we need a control group. So and then we came up with basically the pamphlet. So the pamphlet is information, but the pamphlet information exactly the same of the content of the video. We didn't want to give something different. We just wanted to check the format of information. And then we follow it for 12 months. We did 3 in-person interview and 2 follow up by phone. That's very interesting. I was in all patient interview. I was in patient home in all 300 something interview we did, because I wanted to go there for 2 reasons. One, to make sure when we checking the inhaler, they have 2 observers, Plus, I wanted to make sure, although I didn't understand the language, but I communicated very well with the patient from Mandarin and Cantonese speaking people. So the outcome of interest was the knowledge, inhaler technique, self-efficacy, and basically the evaluation aspects of healthy tracing I'm going to share. So I'm going to give you some base. That is great because we find lots of improvement in terms of, although not knowledge, and that is justifiable because the people at this level, COPD, they have good knowledge. Many of them, they told me, and I mean my assistant, we know that. My physicians, my GPs, my lung doctors, many repeated. And I know that, but I don't know how to practice it. And they basically, so that means the knowledge was high in somehow, but not that much level to change the knowledge to behavior, which we talked today. So that was in some part we saw knowledge. For example, younger people, they improve better over time in pre-test to follow-up. And also we find that people who watch videos definitely improve better than the people who basically just read the videos. Also some information, some knowledge about the short of breath and the self-recognition of the short of breath that was improved significantly over time in different test groups, from pre-test to follow-up and also in the age group. But the biggest improvement and biggest achievement was basically inhaler technique. So most of the basic time, they didn't know how to use the inhaler correctly. And I learned from Mark and many other respirologists that inhaler use is very important because in most best case of scenario, I learned, Mark, correct me if I'm wrong, in best case of scenario, they are going to receive medication 25 or 30% of time if they use correctly. Then if they don't use correctly, so that means they're wasting money, time, and they trust because they say, oh, I'm using medication, but it doesn't help me. So that improvement was basically, we found from pre-test to follow-up in all 3 video groups, and also in basically improvement was at the end, very end, to basically compare to pre-test. And also the knowledge, that is very important. We had 2 important questions about the knowledge about the COPD in general and rehab program. And we tried to give them a passage and ask them to read and respond to some numeracy and document questions. And we found the improvement was basically in terms of age and also from follow-up, pre-test to follow-up. So in general speaking, although it's a low number, just 91 patients, but we observe improvement in terms of basically knowledge and inhaler technique. So the conclusion is definitely by right information, culturally and linguistically appropriate education, we can improve the people's skills to correctly use the medication, which is very important, and also properly manage their illness. I know I'm past the 2 minutes. So language and culture is major problem in accessing, understanding, and using, if those 3 are major components of health literacy. And by culturally appropriate education materials, we can basically come up with basically better knowledge and improve the COPD in these people. So this is the fact, and you can read it. And thank you very much.
Thanks.